You look at hospitals. Work out of Yale has shown that more than half of the communities in this nation have lack of competition. And so hospital CEOs just keep raising rates because they control that marketplace. We're seeing that the majority of doctors now, 70%, are working for hospitals and health systems. And you can be sure that the number one expectation is not around longevity or quality. It's around the finances of the hospital.
Welcome to How I Doctor, where we're bringing joy back to medicine. I joined the Permanente Medical Group in 2011, the largest private physician-led, physician-owned medical group for Kaiser Permanente, Northern California. And when I hear the name Dr. Robbie Pearl, I can't help but think the man, the myth, the legend. See, Robbie was my first CEO of TPMG, and when you're a brand new attending, you're so focused on just getting used to practicing medicine that the only things you really hear about your CEO are stories from your older colleagues. And Dr. Pearl has lots of stories. For 18 years, he ran TPMG, overseeing the medical care for millions of KP members, delivered by many thousands of physicians. And when Robbie retired from TPMG, he didn't actually retire. He started writing books that said uncomfortable things about the culture of medicine. Right now, his argument is a contrarian one. Every hospital CEO in the country is being sold generative AI as a way to maybe cut headcount. Dr. Pearl thinks the math doesn't work that way, that physician and clinical wages are a tiny slice of the trillion-dollar healthcare budget, and so that maybe doesn't matter as much. The real savings, something close to $1 trillion by his estimate, maybe comes from preventing the heart attack or the stroke or the kidney failure in the first place from managing chronic disease better. I'll be right back with Dr. Robbie Pearl after these messages from our sponsors. Dr. Robert Pearl, welcome to How I Doctor.
Graham, it's a pleasure to be here.
Robbie, maybe big picture, how would you describe the state of American healthcare right now?
When I look at American healthcare today, what I see is that the costs are becoming unaffordable. What we're seeing is that American healthcare today is $5.7 trillion. That represents almost $1 in $5 that every American on average spends. And it's projected to rise to over $9 trillion by 2034. Half of our nation can't afford it. And right now, there are no good plans that I've seen about how to change that course. But it's not just that. What you're also seeing is that access is becoming increasingly difficult. What we're also seeing is that medicine is having quality issues, and doctors are being burned out. Half of doctors say they don't feel fulfilled in the profession anymore, and patients are getting dissatisfied. You put all those pieces together, I can't find a lot of positive things that are happening in American medicine today.
How could you look at a system that is spends more than anybody else, and then not only that, we don't arguably have the quality that we expect, even the time with our doctors, like the iron triangle of cost, quality, and speed. Arguably, we have none of those.
If you ask me, how do I explain the fact that we spend almost $15,000 per American on healthcare, basically double what every other nation in the world does, and yet we lag. We're last in longevity amongst peer nations. We're the worst on maternal mortality, infant mortality. We can go on a list of outcomes for which we have major problems. If I had to put my finger on the problem, I want to be clear, I think the solution is going to be different than the problem. But if I had to put it on the problem, it's a combination of two things. The first one we share with other countries, which is the growing obesity epidemic, the growing chronic disease epidemic that we have, the growing unaffordability of medications. We could go down a list of problems, but they're not unique to the United States. What is unique to the United States is how medicine has become monetized, and that's by monopolistic actions. So what you see is that we've had tremendous consolidation. And as a result of that, on drugs, the average cost of a new drug released last year, $300,000. You look at hospitals, work out of Yale has shown that more than half of the communities of this nation have lack of competition. And so hospital CEOs just keep raising rates because they control that marketplace. We're seeing that the majority of doctors now, 70%, are working for hospitals and health systems. And you can be sure that the number one expectation is not around longevity or quality. It's around the finances of the hospital. We could go, we're seeing private equity growing. And when they come in, whether it's to a hospital or to a physician group, their goal is simply to be, how do we lower headcount to be able to maximize profit and sell it in 5 to 7 years? We could go on the entire list. And I think that that's what's different in the United States and why we have been so slow, found it so hard to be able to make the changes that would be needed in order to, I'll say, get out of being, in quotes, in the lead, which is really trailing the pack by a massive factor.
Robbie, I want to take you back 15 years because this is one of my first memories of you gathering my medical group at Kaiser San Francisco over lunch and watching a video that was really preparing us for Obamacare, the Affordable Care Act. And you had everybody in the med group watch a video that you kind of warned us, hey, we don't know what's coming here. We need to kind of tighten our belts. We need to be ready that rates may go down. We're just not sure what's going to happen. And I'm curious, as a leader, you having to probably deliver a really difficult message to 10,000 doctors and another 50,000, other nurses and pharmacists and social workers. And I'm curious, you looking back now, what do you think you got right about what you thought Obamacare was going to be, and then maybe what it turned out to be that we have now? What's worked well? What surprised you about what ended up happening with Obamacare?
Let me start with the legislation itself. And at the time, what I pointed out is that President Obama came into office with a history in Chicago of being very involved in the community, being a community leader. And he saw the consequences of difficulty accessing medical care. He knew that access was a problem. He knew all of the issues, but he's a very smart man. And what he said is, I can't tackle all of them, but I want to start with the foundational one. If you can't get access to care because you don't have healthcare coverage and you can't afford it, then the quality is going to be terrible no matter what is like for the people who have that coverage. And you can't get access because no one wants to take care of you if you don't have coverage. And I pointed out at that time, and I emphasize that should be the start of the process, not the end. And I think that was a big mistake. Our country thought, okay, we're done. We did it. Healthcare.
Yes. Finally, we
No,
got there. Yeah, yeah.
we solved one of three problems, and we were able to drop the uninsured rate in half to be able to do things that we otherwise couldn't. It was not a question of what I liked or didn't like about the Affordable Care Act. It just, to me, was incomplete. And ever since President Obama has left office, it hasn't been completed in the way that I think that it needs to be.
Robbie, maybe I can pivot there and just ask you your vision. You've written so much about your vision for AI and the future of medicine, the future of healthcare delivery. I'm curious how you view generative AI. Will it be able to address some of these gaps that we're currently seeing? Like, what's a perfect system look like to you?
There is no question in my mind that the combination of dedicated clinician with empowered patient generative AI will be able to achieve clinical outcomes exponentially better than any of the three alone. Yes, I think it is the solution. When I was in Kaiser Permanente, the challenge was being able to get all of the pieces accurate. You want to have the best quality, you want to have the best access and service, and you want to do it at the lower costs. That was challenging. Today, I think it's much easier using a generative AI tool. According to the CDC, 30 to 50% of heart attacks, strokes, kidney failures, lower limb amputations come from chronic diseases. We're talking about if we could control those factors, if we could better control diabetes, heart failure, um, uh, kidney problems, lung problems, heart problems, all the different aspects that go into chronic disease, we would save $1.8 trillion. First of all, we shouldn't forget that a major reason we have all our chronic disease is obesity. So we need a plan to make GLP-1 drugs available. We also need to do lifestyle changes and exercise. I'm a big runner. I run every single day, 35 miles a week. But what I recognize is that for many Americans, it's just not possible. But GLP-1 drugs do work. They'd be able to reduce total body weight by 15 to 20% in the injectable form, and the new pills are 10 to 15%. That would make a major difference. So I think
Yeah.
of that, again, on the preventive side. But I also recognize that probably most of the people who develop a chronic disease today, diabetes, the causes frequently, most often, going to be obesity, liver fat. Another problem that sits there comes from
Yep.
obesity. All right. And I think the underlying problem is that the American healthcare system today is so episodic. You come to see a doctor, he or she diagnoses hypertension, they start you on a medication. They say, I'll see you in 4 months. What happens over those 4 months? We have no idea. They come
Yeah.
back in
No
4
clue.
months, the blood pressure's still elevated. What do they say? White coat syndrome. Come back in 4 more months. It's 8 months, 12 months. We never are able to get that level of control. So just imagine having a generative AI tool in the patient's home that by Bluetooth connects into their wearable monitor. And the wearable monitor could be uh, at the bedside, it could be a watch, it could be a whole bunch of ways that we can access data frequently. Now, the tool, a generative AI tool, looks at that data. It does a first and second derivative calculation. It either says to you, you're getting better, you're staying the same, or you're getting worse. Well, obviously, if you're getting worse, you better get care right away. But if you're not getting better, what do you do? This is where, unless you know about it, you can't take action. But your doctor now, by the way, no doctor wants 100 blood pressure readings every month. It would
You're correct.
overwhelm the
Yeah, I will.
majority of
I will
people.
agree with you there. Yeah.
Another good example is it's 11 o'clock at night. Kid spikes to 103 fever. What are they going to do? They call the doctor's office. What do they hear? A recorded announcement. Go to the ER if you're worried. Well,
Yeah.
I don't know if I'm worried or not. What should I do? They go to the internet, social media. No, they want to know what I should do. Do I go to the ER, spend an hour waiting for care, surrounded by people who are infected? Or do I wait till the morning until the doctor's office opens? If I wait till the morning, my child could be dead. If I go there now, they don't know what to do. And the idea, Graham, that people say, well, we can't prove that a generative AI tool is 100% accurate. By the way, for listeners who may not be in medicine, the data says that it's actually far better right now than clinicians. Research out of Stanford has shown that if you take patients going to the emergency room and you compare the actions of doctors against a generative AI tool, the generative AI tool is significantly better, both at making the diagnosis and providing the treatment. Anyone who thinks that no information to the parents is better than information that's really quite good, but may not be perfect, I don't understand how they come to that conclusion. So I
Yeah.
see this opportunity to be able to completely transform American medicine, control chronic disease, avoid the complications of heart attack, strokes, kidney failures, and be able then not only to lower costs, but to do so by raising quality, extending longevity.
Robbie, I couldn't agree with you more. I'll see patients in the ED who, I say, "Oh, how long have you been how long have you been breathing like this? How long have your legs been swollen? They say, oh, 3 or 4 days. And I have to always react like, this seems like a solvable problem. Like, if you really have been breathing this hard for 4 days, gosh, it seems like we could figure this out. This isn't like a mystery. This isn't a magical thing. We know you have congestive heart failure, or we know you have chronic obstructive pulmonary disease. Hey, when someone starts breathing a different way, could we make it so that it doesn't take us 4 days and we intervene on day one or day two? And generative AI could certainly help us do that substantially.
Let's acknowledge it and then say, could generative AI do it better than nothing? I mean, that's the reality of every new technology. We measure the technology against perfection. We measure doctors about what's possible. No, let's measure how we're doing today
Love that.
and then say, if 500,000 people are dying from poorly controlled chronic disease, could we do better? And I guarantee you we could cut that in half.
Oh, Robbie, I love it. I love your passion. I'll press you here. Let's say you're in charge of all of healthcare, whatever that means. Where is it that we need to get to that future vision? Is it we need investment? We need regulatory change? I mean, what's holding us back? Maybe is the way to ask that. Do you think?
I write a lot about this process of monetization. And what I point out is that generative AI is different than the tools of the past. We had a major advance with the introduction of the MRI or the CT or the operative robot. But in doing all of that, it was very expensive. We know generative AI is relatively inexpensive, $20 a month for the really advanced program. Others are even less expensive than that. But it's still a cost involved. So I think that we need to have a community-wide view of how do we provide access to generative AI for everyone. In some communities, it may be at community centers, could even be at churches. It could be wherever people are that they can't access a tool. The second thing we need is we need to be able to educate them, train them. It could happen by entrepreneurs, and that's why I write for Forbes and encourage the people to do it. So I'm going to tell my business school classes at the upcoming semester at the Stanford Graduate School of Business. But I think it's a role for the NIH. I think it's a role for the major national medical societies to be able to say, okay, we're cardiologists. We have patients who are in chronic heart failure who may go into acute failure. How do we provide the expertise to the patient? And as part of that process, we're going to have to make some advances, by which I mean make sure that the scale actually has the Bluetooth to the generative AI. It's not that any of this stuff is going to be free. But as you well know, when you admit a patient out of the ER to the CCU because they're in acute heart failure, you've just created a $200,000 bill. It's not going to be that hard to figure out how we can make this very cost effective. And again, I want to stress to listeners, as opposed to everything else being talked about in the nation today, we are lowering this cost because we're keeping people healthier.
Probably, I love it. I mean, Claude is, even the max Claude plan is $200 a month. You could imagine, I don't think you probably need that level of Claude access, but like $200 a month times 12 months in a year for 30 years is probably 10% of what it costs for one ICU admission once. And so like I think you're right in terms of the scale. You can fundamentally you can offer the Max Claude Pro Max plan, whatever, to every single patient or to thousands of patients for the cost of one cabbage, one heart transplant, one thing that could be, potentially prevented. I couldn't agree more. The ability to scale and the cost seems economically possible, I think.
The cost saving is $1 trillion, and I can't come up with enough plans
Yeah.
for Americans to cost me $1 trillion. So yeah,
Well, I loved the way that you talked about the savings, because you said savings, and then you also kind of renamed it as an investment too. And I think that's the right way to look at it. Not only is it savings for society, it's an investment in our people. It's an investment in new ways of delivering care and practicing medicine. I mean, I think that's the way to not talk about it as just like this monolith of like we're going to cut costs or something like that, but we're actually going to be investing in a new way to deliver care, investing in the future, and investing in having Americans be healthier and live more years where they're able to enjoy their lives. That seems like a pretty good thing to invest in.
Absolutely. It's why, if you ask me who's going to lead the way, I'd like to think it's the government. I don't know what you feel about it. I see a lot of logjam out there. I think it
Yeah.
should be, and I'm hoping it could be. And I actually will be speaking to a lot of the self-funded investors, the companies that provide coverage for their own people. If you look at the 330 million Americans, about half of them have insurance either through their work or through their parents' work or through someone in their family's work. And about half of those, so now we're talking about 80 to 90 million people, their company provides the coverage. They don't buy an insurance policy, they're self-funded. And I think that would be terrific for exactly the reason you just said, Graham. Not only will that lower their healthcare costs, but it will keep people healthier. I mean, when people are absent from work, that's a cost, but the productivity is even a bigger cost because the person who knows how to do the job isn't at the
Is
job
out.
today. And
Yeah.
5 people may be dependent upon that one person. And now you've kept that person at work again, not by some coercive fashion, but by keeping them healthy and
Yeah.
letting them avoid that chest pain that otherwise would have happened and kept them out of work for 6 weeks or 3 months or whatever it was that the doctor recommended.
Yeah. Robbie, I have a couple more questions, and I'm realizing one question about the future may not even make sense with your new vision. So maybe we need to reframe this question entirely. I was going to ask you, 5 years from now, what does a routine visit look like if Gen AI does everything you're hoping to? Maybe there's not even a visit. I don't know.
The first thing is you would start with the generative AI tool. Now, again, I think certain patients who have problems that are so complex or situations that are so irreversible, I like your word a lot. No, they wouldn't start there, but they would start there. And a great example to me is early on after I wrote the book ChatGPT MD, I was on a podcast and the host had never tried a generative AI tool. And she said to me when we were off air, she said, my husband fell skiing a few months ago, 3 months ago, and his arm was over his head. He slid down the mountain 100 feet. Dr. Pearl, you're a big skier and you're a doctor. What's going on? He still can't use that arm as well as the other side.
Oof, that's not good.
Yeah. And I said, I think I know exactly what's going on. But do me a favor. You said you've never used generative AI tool. Go home, put the information into place, and just see what it says.
Yeah.
Five days later, she calls me and she says, thank you, Dr. Pearl, so much. Did exactly what you said, and it said he probably has a rotator cuff tear. And then it explained to me what the rotator cuff was. It showed me the anatomy, it explained all the pieces there. He said he needs an MRI to see whether the tendon has been pulled off the bone or not. And he should see an orthopedic surgeon because he almost definitely needs to have a procedure done. So they went to see the surgeon. The surgeon said, yeah, probably have a rotator cuff tear. She didn't have to ask, what's the rotator cuff? He
Yep.
ordered an MRI. She didn't have to say, is it really necessary? And when he did the procedure, he said, if he'd waited 3 more months, I probably could not have gotten the tendon to reattach to the bone because the muscle will have shortened. That is the kind of process that I see happening.
Yeah.
Certain things are going to be able to be taken care of by the generative AI tool. And if the patient doesn't get better, as happens in medicine all the time, the patient needs a referral to a human clinician. That's how I see the human clinician.
Yeah.
Obviously, a lot of the times, if we're talking about doing a procedure or we're talking about being able to prescribe a medication today, although in Utah, you probably know that generative AI tools are at least doing medication refills. So there's certain reasons why you then have to see the clinician. But again, every time we can diminish the needs to see patients who have the kinds of problems that can be easily solved, frees up the time for the clinician to take care of these patients we talked about, whose problems are so complex or whose problems are so irreversible sitting there. So that's how I see the progress. It's going to start. Now, people who think that's crazy, right now, that's what the Cleveland Clinic does, by the way. That's what Mass General has done as part of a research project that they were doing. And the answer is what the technology recommends is almost identical what the doctor is going to do. Is it perfect yet? No. But remember, this technology is doubling in power every year.
Yeah.
5 years from now, when you said it'll be 32 times more powerful, that's like your car going as fast as an airplane. And so, what I would say to you is don't think of the technology that exists today. I actually do consult it before I talk to my doctors
Yeah.
just to see what it's going to say. And so far, it's been identical,
Yeah.
essentially, in terms of both the information and the recommendations that sit in play. But if you don't think it's ready today, you can wait 3 years or 4 years or 5 years. But that doesn't mean wait and just wait. I don't think that we're going to start using this technology because some regulatory agency, the FDA, has given it a seal of approval. It's going to happen because people have enough experience with it. And they say, wait a second, if I'm getting exactly the same advice. Now, everyone says, what is it tells me to cut my leg off? You're not going to cut your leg off. You know you shouldn't cut your leg off. It's not like you're going to do whatever it
Yeah.
says. It's just going to give you enough information to let you now decide how you want to get your care. I
That's
just
right.
think, unless it's an emergency to call 911, I think you're talking about we should always start there. But you need a clinician. And this is where I also say to the physicians out there, this is why we have to change how we run our offices, how we organize care delivery, because now you're not getting a patient calling to talk to your secretary who's booking an appointment, who's asking a couple of questions, but you don't really know what's going on. You know what's going on. You can figure all this out. And if we can build that into the systems, now we can figure out what to do. If someone has a problem that needs care, you might as well see them today. You might as well order the test today. You might as well get it done. There's nothing good that comes out of waiting. And on the other hand, if they don't need to see you, it's good that the expertise can be provided to them to reassure them so that you have the time that you need to provide to the patients who are going to benefit from your training and experience.
Amazing. Very well said, Robbie. We are starting to see some small businesses just say, hey, we're not going to provide health insurance anymore. It's just too expensive. You can figure it out on your own. That's just not a benefit that we offer. We are seeing some, I think mostly young people, kind of opt out. Yet the whole concept of insurance says that you need as many people in the system as possible so that when you're healthy, you pay into the pool, and when you're sick, you can be covered. That's like car insurance and homeowners insurance. How do you think this ends? Isn't that a downward spiral we end up in for the people that have expensive, serious illnesses?
It definitely is a downward spiral, and we're seeing that, by the way, right now in the healthcare exchanges, the ACA exchanges. As an individual, you and your family can only get coverage if you go through an exchange
Yeah.
because you're a so-called, in quotes, N of one. And we're seeing that right now. In fact, hospitals are reporting this week a tremendous increase in the number of uninsured who are coming to them. They had
Oh,
costs they're having
interesting.
to bear.
Yeah.
Because the government ended the premium subsidies, 4 million people out of 24 million will have left the exchanges this year. And as you say, gone without insurance. And many of them are the young individuals.
Yeah.
If you asked me, you gave me my magic wand that you said to wave, what would I do? I would shift reimbursement in healthcare from fee for service to capitation. Fee for service is pay for volume. The more you do, the more you get paid. Does it do any good? No one knows. See a patient for the same problem twice rather than once, you get paid twice as much. It is absurd.
Yeah.
In fact, sometimes, not in Medicare, but in other coverage, you create a complication, you get paid twice. Once to create the complication and once to solve it, doesn't make any sense. Capitation, a single payment, and I want to phrase this, to a group of doctors. No single physician can take a capitated payment. Their population is too small. For whatever reason, 3 people get a heart attack or one needs a transplant. And yeah, they might have coverage through stop gas loss, but no, for the most part, they just can't do that. But a group of clinicians could take a single payment to take care of a population of patients. And now you have a unique situation because now you can do exactly what you're saying. Because the individual who you're describing, who's very healthy, because by the way, as you said, the sick people in the exchanges, they had to come up with the money because they knew their costs would be so much greater. Now, the individual who is very healthy, you're happy to take them at a much lower reimbursement, in essence, because they're not going to need much care unless something unexpected happens. And at the other end, you're getting enough reimbursement that you're not going to say no to patients who have heart failure or something else, because the dollars you get are going to reflect the demand that, at least statistically, you'd be expecting. Now, once you have that in place, you align incentives. What did Charlie Munger say? Tell me your incentives, I'll tell you the outcomes you're going to get. In a capitated system, now you want to invest in health. Now you want to use generative AI. You don't want to use it in a fee-for-service world because those easy patients make you a lot of profit because it only
Yes.
takes you 10 minutes to take care of them. No, now you have the opportunity to be there. Now you have the opportunity to do collaboration, cooperation, to share data. Every incentive that I can think of aligns not just in what's good economically, but what I would want for the healthcare of me and my family. That is the opportunity that is there. So the answer to your question is, if we can move from fee for service, I don't like fee for service, call it pay for volume,
Sure.
to capitation, which often is called pay for value, although I like to think about it as paying for health, creating health. Now we have the opportunity to focus on prevention, to better manage chronic disease, to figure out how we can address social determinants of health, how we can provide care more easily 24/7, not with the clinician, but with a generative AI tool, but backing it up with a small number of doctors, probably ER physicians like yourself, who will now be available to take care of large numbers of patients, because 99% of them won't need care tonight,
Yeah.
but you just don't know who they are. And now you can cover many of your colleagues and they can cover you for the rest of the days this month. That's where I see that we have to go. And that's what I see, um, the first step. Because if we don't embrace capitation, I'm moderately pessimistic that what we're going to see is that people will not make the investments because they're not going to get the size of the return that's necessary, because they won't have the personal economic incentives. As you know, as we talked about, I teach in the business school, so I often think about that. I
Yeah.
can't think of any other industry like the one we have where you can get $1 million worth of care, almost predictable care based upon your underlying health condition, and not have to pay very much of that. That would be seen as a problem of the so-called commons. And I think that's what we have in the United States today.
Robbie, this has been outstanding. Uh, Dr. Robbie Pearl, where can people find your columns, find out more about you, follow you, and learn more about you?
The best thing they can do is go to my website, robertpearlmd.com. There they can sign up for my monthly musings with 80,000 subscribers. On my monthly musings, you can find out where I'm writing these days. Twice a month, I write for Forbes. Every week, I have a Fixing Healthcare podcast. And please do me a favor. Let me know what you're finding and thinking. You can provide feedback on the website, because that's how I learn. And if the things that I'm saying don't make sense, if they don't align with the realities that individuals face today and the opportunities for tomorrow, I want to know about it so I can change what I write. I don't want to mislead people. I left my job as CEO because in that role, I was responsible for the healthcare of 5 or 10 million people, depending upon how you want to measure it across the country. Now I see myself as wanting to improve the health and the stability of 330 million Americans and hopefully 7 billion people around the world. Big hopes, small likelihood of success, but every day is a day of progress. Thank you for having me today on the show, Graham.
Robbie, it's been so great. Thank you. I really appreciate it. Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.